Celine, we're going to start with the first speaker. Unfortunately, our first speaker is not live here at the event because he leads a very busy life. It's going to be a recording of Dr. Christiana Gordon. She is the dermatologist and the lead of the clinic in St. George's Hospital in London, the UK. She is becoming a very famous doctor. She is it already, but she will be more famous in the future. She is the successor of Professor Peter Mortimer, and she has done some amazing work for the ILA, the International Lipedema Association, but also for the lymphedema patients in the world. Today we have asked her to talk about the study they're doing. It's a huge lipedema study sponsored by partly the NHS, the English healthcare system, and we would like to know the first results. So we're going to start the recording. The recording is not starting yet. Yes, there it is. You can see and
Welcome
hopefully
to
hear
the second
Christiana.
Medi Lymphology 360 Virtual Summit. My name's Christiana Gordon. I'm a consultant in dermatology and lymphovascular medicine at St. George's Hospital, and I've been asked to speak with you about the lipedema research that we offer at St. George's Hospital in London. These are my disclosures before we begin. So many of you in the audience will know what lipedema is, so perhaps these next few slides are just a refresher for you, but there may be some audience members that aren't yet familiar with what lipedema is. Well, lipedema is a chronic condition that, in my opinion, only affects females. There are perhaps 2 or 3 males that I have in clinic that have something that might be lipedema or mimics lipedema, but interestingly they've all got estrogen abnormalities, so perhaps there's a link there. But if we think about lipedema in the main, what is it? Well, it's a chronic condition that affects females, and it's characterised by the enlargement of the legs and or the arms due to an abnormal deposition of painful fat. And it was first reported by Allen and Hines in 1940, but it's really only been in the last 10 years or so that this disease has been recognised by healthcare professionals. What's interesting about lipedema is the women have disproportionately enlarged lower limbs and maybe the arms, but their feet and their hands are not affected, and so it creates a bracelet effect just above the ankles or at the wrists. The onset of the painful lipedema fat is often noted at times of hormonal change or weight gain based upon the patients that I've cared for. So puberty, pregnancy, taking the contraceptive pill could all be times of triggering this condition, but I think times of weight gain also seem to feed the problem as well. And frustratingly for these women, once the abnormal fat has developed, if they decide to try and diet to lose weight, these areas show a resistance to dieting. In fact, there are some clinicians and a lot of social media forums that say that weight loss has absolutely no effect on reducing limb volume. What's also important to note about lipedema limbs is that the volume doesn't reduce with limb elevation or compression, and that's because this is a fat problem, not a fluid problem. So for those of us in clinic seeing patients referred with swollen limbs, these are the 2 conditions side by side that we might be seeing and trying to differentiate between. You have lipedema on the left and lymphedema on the right. So you might be able to appreciate from the clinical photos that the components of the swelling, if we should use that term for now, is very different. The lipedema, you can see it's a fatty, floppy tissue hypertrophy that seems to have rolls of subcutaneous fat collecting throughout the lower limb. Many of my women have medial knee fat pads where the fat seems to be more problematic. And then you have the braceleting cut off above the ankles. There's sparing of the feet. And on this lady on her left shin, there's quite a typical bruise. Easy bruising tends to be part of the phenotype as well. And this contrasts to the patient on the right that has lymphedema. Lymphedema typically presents distally before it spreads up the leg, so the feet are affected often before any other part of the limb swelling is noted. And this patient has asymmetrical swelling, which is more common in lymphedema. So lipedema is a very symmetrical issue, whereas lymphedema might not be. And this would be this patient on the right with lymphedema. They would have pitting. So if you pressed hard on the shin, you'd be able to make a dent, and that's because the predominant cause of swelling in these limbs is fluid accumulation from lymphatic impairment. But it can be difficult to tell the two apart. So there have been attempts to try and make it easier for clinicians to differentiate between lipedema and lymphedema. And this table has been created that does help some healthcare practitioners just starting out in clinic trying to differentiate between lipedema, because what we know is that it's not obesity and it's not lymphedema, even though lipedema is often misdiagnosed as these conditions. And here's a table just trying to help the clinician differentiate between the condition based on the clinical signs that may or may not be present. So, still thinking about what is lipedema. Is it a rare or a complex disease? It's really difficult to know the answer to that one. There's so many contrasting reports out there. Very few studies have done proper prevalent studies on lipedema. I suppose some of that might be because it's quite a difficult condition to diagnose. There's no diagnostic test at the moment. There are some studies that rate lipedema as being, very prevalent. 11% of women and postpubertal girls were reported to have lipedema from the Foldy Clinic and Karen Herbst's team in more recent years. Our original lipedema study in 2010, we felt that it might have a prevalence of 1 in 72,000. And then, looking at studies trying to identify how common it might be in patients attending a lymphedema clinic, noted that just under 20% of patients referred with swollen limbs seen in a lymphedema clinic had a diagnosis of lipedema. So it's very difficult to understand whether lipedema is a rare disease or is it something that's very common. And when we're thinking about prevalence and incidence and so on, we need to start thinking about, are genetic factors involved in this? Are environmental factors involved in this? And what's becoming clear is that the more I study this condition, the less I know about it. There is so much yet that we don't understand. Why does lipedema develop? Is it a genetic problem? Is it an environmental problem? What's the fundamental abnormality with the fat? Is it the same fat cell that someone with obesity might have? Are there more fat cells? Are they bigger fat cells? Are they behaving differently? Based on my clinical experience, I think there is a link with obesity, but I don't fully understand it. But certainly many women coming to my clinic will struggle with obesity. I wonder, is there an association with inflammation? There's some emerging evidence to suggest that might be the case. Questions that I want to try and understand and answer is, why does lymphedema develop in some patients but not all? Could there be an underlying lymphatic problem like in primary lymphedema? And the reason I start thinking about this is there is emerging evidence that the lymphatic system is linked with the inflammatory pathways and the adipogenesis pathways. So who knows whether there will be a link with the lymphatic system? And something that we're keen to try and understand is there a genetic cause for this condition? And if so, is it one gene? Is it multiple genes involved? But what's becoming clear is that research in lipedema, up until recently, it's just been severely lacking. And we need to make sure that we're not doing research in isolation. We need to collaborate, both as clinicians and scientists. So we need to work together. So what are we doing at St George's Hospital? Well, my main job is as a clinician. I run one of the 2 national lymphedema clinics in the UK. We're tertiary referral, which means that we can only have patients referred to us from other consultants. We can't really accept referrals from the local doctors. We have 16,000 consultations a year in our clinic for patients with lymphedema and lipedema, and in the last 3 to 4 years the number of referrals for lipedema has dramatically increased, and I suspect that's due to more awareness of the condition amongst healthcare providers, but also amongst patients on social media platforms. So our focus at St George's is on diagnosis and medical management rather than surgical management with liposuction, although we have offered it to a few patients where funding has been available, but it's very difficult in the UK to get funding for it on the National Health. And from our clinic we will recruit to research studies to further understanding of the mechanisms of disease and genetics in both lipedema and primary lymphedema. And these are my wonderful colleagues in the genetics research team, Professor Pia Ostergaard, who does all the clever science stuff, and Professor Saha Mansour, who's the clinical geneticist doing all the clever clinical genetic stuff in clinic. And then we have a team of scientists in the lab doing the research. But as I said before, it's all about collaboration, so we can't work in isolation. So I am delighted to be part of the International Lipedema Association. This was formed fairly recently and is a collection of like-minded, motivated, inquisitive clinicians and scientists that want to know more about lipedema, that want to work together, want to try and answer all of the questions that are unanswered about lipedema. So please do have a look at the website, and please do consider becoming a member if you wish. Here's a picture of our last meeting, and we have over 60 founding members from over 20 different countries across the globe. And the hope is that we can work together to improve knowledge about lipedema, to do some myth busting, to promote good scientific work, to eventually lead to better care for these poor patients that struggle with lipedema. So back to what we do at St George's Hospital. Well, as I said, we are collaborating with several other research teams across Europe, but the focus in our lab is on understanding the genetics of lipedema. And this interest was based on the family tendency. So the research pre-2010, my work as a junior before I became a consultant, was based on the frequent observations of mother-to-daughter mode of inheritance, which led us to hypothesize that lipedema was a genetic disorder. And I think this hypothesis had been shared by others prior to us. So this was one of the patients that I met fairly on in my career. She's a young lady, well, she was young then, and you can see that she has a relatively slim torso and then disproportionate fat deposition from the hips down to the ankles, and it was painful for her, and she did her best to reduce the volume with weight loss and exercise, but it was just very resistant to that. So she has lipedema, and then she invited the rest of her family to come to clinic, and you could see my lady in the middle and her identical twin sister to the left of her in the pink underwear. She also has lipedema. The girl on the left is not showing any clinical signs. That's the daughter of the lady with the pink underwear, but the lady with the white underwear, her two daughters are to the right of the slide, and they were post-pubertal, and you could see that they were sharing signs of inheriting their mother's and aunt's tendency to lipedema. So we wanted to recruit these patients to take part in research, and so we set about trying to do a small study. And in this study, the patients were all identified from the tertiary referral lymphedema clinic run at St George's Hospital. Interestingly, they were all referred to our clinic with lymphedema, highlighting the frequent misdiagnosis of these patients. And so these patients very kindly consented to take part and have blood taken for DNA analysis. But it's worth saying that this was pre-2010, so the genetic research was very basic compared to what can be done now. Basic in terms of the technology that we had, and also time was a real rate limiting step. So in this study we recruited a number of families, and these are pedigrees, so these are generations within each family. There's 5 families here that we listed. The family you saw the clinical slides of are represented in the top left, LI01, and you can see the identical twin sisters that are affected, so they're coloured in with black, and one sister has an unaffected daughter represented as a white circle beneath her, and the other sister has 2 affected daughters represented as the black circle. So you can appreciate the pedigrees here in the 5 families showing multi-generational families with lipedema affecting the women. And so we took their DNA and analysed it, and rather frustratingly published our paper in 2010 without finding the causal gene. All we could say based on our research was the observational statement that the familial nature of lipedema suggests a heritability, but no cause at that time. So we continue to see these women in clinic and continue to be frustrated that we still didn't have an answer, although we were convinced that there was a genetic basis to this disease. So eventually we managed to secure funding from the Lipedema Foundation, and undertook the lipedema NGS study, next generation sequencing study. And the plan here was to recruit 200 women from the clinic. We had to do a clinical assessment to make sure they really did have lipedema. It wasn't just a case of a lady writing in saying, I've got lipedema, I want to be part. We had to see them first to make sure they really did have lipedema. We also wanted to do some quality of life research, as well as the genetic research where blood was taken for DNA analysis. And that DNA was analysed using whole genome sequencing. So which patients were we going to include in our study? Well, we had to be strict. We'd realised from our own research pre-2010 and perhaps from critiquing papers from other authors that often patient selection perhaps wasn't as good as it could have been. Did some of the patients have lymphedema? Did some of the patients have such severe obesity you couldn't really tell if there was lipedema hiding underneath the obesity fat? So we decided to be quite strict with who we recruited to our study. We only wanted female patients. The age at diagnosis of lipedema ideally was going to be after puberty and ideally before the age of 35. And the reason behind that decision was to try and identify women before obesity had complicated the clinical picture. So we wanted to get them early. We wanted patients to not struggle with severe obesity, and so we intended to recruit patients that had a BMI equal to or less than 40 to try and exclude that confounding factor. We also wanted patients to have a waist to hip ratio equal or less than 0.85. So we wanted them to have a slim torso and disproportionately enlarged hips and legs. And again, the reason behind that was to try and exclude obesity that could be complicating the clinical picture. And we tried to do that as well on the clinical assessment, trying to avoid recruiting patients with central obesity. We also wanted them to have the classic signs of bilateral symmetrical fat hypertrophy and preferably soft and floppy to the touch, and we wanted sparing of the feet and confirmation that the enlargement of the legs was persistent despite elevation and compressions, thereby excluding lymphedema. We didn't have the option to do lymphoscintigraphy on all of our patients though. And for the purposes of comparing our DNA to that of controls, we were recruiting patients belonging to white British ethnicity groups only. So here's an example of patients recruited to our study. You can see that their BMIs range between 23 to 38 on these slides here, and the waist-hip ratio was within the range that we wanted. So they have relatively slim torsos and then disproportionate fat deposition of the lower limbs. And the lady on the right also had disproportionate fat deposition on her upper arms as well. So classic cases of lipedema that we all felt very comfortable recruiting to our genetic study. There was a lady that was recruited to our study that had previously had a BMI over 40, but we allowed her to be recruited to our study as she'd undergone bariatric surgery and lost a significant amount of weight. And it was actually that process that unmasked the fact that she had lipedema. She hadn't been aware that there was disproportionate fat deposition until she lost her obesity fat. And because the patients that I've worked with, I've been looking after them for so long, and so has Professor Mortimer, there were one or two that we snuck in that perhaps didn't fulfil the inclusion criteria at that time of recruitment, but we did allow one or two in because they were known to us for many years, decades in fact, and we were confident they did have lipedema, but unfortunately obesity had complicated the clinical picture over time, which is the case for many women that don't get an early diagnosis. So what were the results of our assessment? So in our cohort of 200 women, this is the data that we collected, and you could see that age of onset was typically around puberty for the majority of our women. And fortunately, the majority that were recruited had a BMI less than 40. So we can hopefully be confident we've only recruited women with lipedema. But as I said earlier in the talk, we don't have a diagnostic test yet, so it's always tricky to be 100% certain in the presence of obesity that you've recruited someone that does have lipedema. And of those individuals that did have a BMI over 40, they were patients that were known to us for many years, so we were confident they did have lipedema. What's also interesting to note in our patients that edema was present in some of the patients, but they typically were the older patients. So we didn't really notice edema, lymphedema in our women with lipedema. Some of the websites and forums suggest that varicose veins are very common in women with lipedema, but we really didn't find it to be very common in our cohort of patients. The women with lipedema definitely reported problems with tenderness and pain and easy bruising. What was really interesting for me, and something that supports my clinical experience, is the self-reported responses to the questions about dieting and weight loss. Can you say whether your legs get smaller after you've lost weight? When you address your obesity, does the limb volume reduce? Because the internet suggests that that's not the case. Well, actually, of our women, only 7.8% said that they could not lose any weight from their legs when they lost weight. 86.7% said that they could lose weight from their legs, but it was just disproportionate. It was slower than the fat that they lost from their face and their body. So I thought that was very interesting and did support my experience in the clinic, and also reinforces my message to encourage women with lipedema to lose weight. Yes, it's going to be frustrating, as it may make your legs look even more disproportionate when you get to the point where you have a very slim torso but still have bigger legs, but it can only be a good thing to make those legs lighter and smaller in the long run. We looked at the results of the Quality of Life questionnaire. It was an SF36 Quality of Life questionnaire, and for those not familiar with these, it can be rather confusing when you start looking at these. So these are results plotted in a grid, and normal and healthy and happy is represented as the outer green ring. So the responses from these healthy, happy people report better physical functioning, general health, not having problems with bodily pain, social functioning, emotional well-being. The results of patients with lipedema are plotted in the red circle, shall we call it. So they're closing in towards the centre of the diagram. And those patients have significantly worse or poorer feelings about their emotional, mental well-being, their pain, their physical functioning, their general health. And it's fair to say that the lipedema cases are comparatively similar to patients that suffer with chronic neuropathic pain. So it really does reinforce that message that having lipedema is not much fun. These patients are suffering, and we really should do everything we could to help them. So then, looking at the results of the genetic studies of the patients that we recruited, we went back to the 5 families that we did in our original study. We recruited them again to this study, and also when looked at the exome sequencing from our old families, there was no overlap of potential pathogenic variants identified in these new ones. So based on this, if lipedema is a single gene disorder, then it's a very heterogeneous condition. We need to explore other things, like, is it a digenic, oligogenic and complex traits issue? So definitely food for thought here. So then, looking at the genome-wide association study, this is a better method for exploring diseases that might not be due to just one gene. So we genotyped data from our lipedema cases from the white British background, and then compared them on the GWAS study. So here you have your controls, as evidenced by the orange figures up the top, and these were 5,500 healthy female controls whose DNA had been collected and was available for comparison, and then we had our 130 cases that we felt were the best cases to put forward for this GWAS study, and DNA was extracted and compared. And what you want to do is look for associations between genetic regions. And here's a rather confusing diagram where you plot any variants. So all of us have genetic variants. None of us are perfect. We've all got little mutations, perhaps hundreds of them, but they're not all disease causing. So what you want to try and do is compare your mutations that you identify in your patients with controls and with each other, and try and see if there's any patterns. And so of all all the samples that we analysed, 25 SNPs or polymorphisms were identified that were considered significant. And 9 of those were validated. So 9 of those were thought to be really interesting, and we thought should be explored further. And of those 9 variants, those 9 gene mistakes, that associated with lipedema, 3 of them were found to be on the same chromosome. So there's definitely a region of interest on chromosome 13 here. Just doing a little bit more digging about those 3 mutations, those 3 SNPs, they're in one distinct area of chromosome 13 that was clear next to the LHFPL6 gene. And this is a gene that has been reported an association with lipomas before. So there's definitely something of interest going on. Could this be significant? It's difficult for us to be certain based on these results alone. So what we've done is we've published our data. It's out there in the public domain to encourage other researchers to help us crack the case. So if you're out there and you're interested in trying to help us and others understand the genetics of lipedema, take a look at our paper. Because, you know, we didn't feel it was right to hold our cards close to our chest. We wanted to share our data before we'd cracked it, because this isn't going to be an easy condition to crack. If it was, we'd have done it by now. So to summarise the genetic studies from our recent efforts, we feel we have identified perhaps a causal gene, perhaps areas of interest for the lipedema gene, but this does need to be confirmed. We need help from other researchers, from other groups of patients. And of course there will be other causal genes that we have yet to identify. I don't believe it's going to be a single gene disorder. Perhaps it'll be something similar to primary lymphedema, where we know that it's not just one gene that causes primary lymphedema. There's many different genes, but each with their own different diseases and different conditions. Perhaps there might be something similar in the story of lipedema. But we need help to do this. We need more research, and to do research, sadly, we need funding. And so we're very grateful to the Lipedema Foundation again to support our ongoing analysis studies, because, you know, there's so much more to learn. What we did find interesting from our recent study was the clinical data. There was less lymphedema and varicose veins than I'd anticipated, based on what the literature up until now had been telling me I should be looking for in my patients. And it was really helpful for me to have that message reinforced that less than 10% of women with lipedema reported an inability to lose weight from the limbs with weight loss. And it was also important, I felt, that the quality of life data supports how debilitating this condition can be, just reinforcing that message that we really do need to take these patients seriously and help them. And we are making progress, albeit slowly, in understanding why lipedema happens. But, you know, hopefully if I'm invited to speak again in a few years, we'll understand more about this disease and hopefully have more that we can offer these women, because they really do have a difficult disease. And we don't want any of our patients to end up with lipedema like this, because that's no way to live. Thank you very much for your time and attention. It's been a pleasure speaking to you, and enjoy the rest of the meeting.